Good afternoon, everyone. Welcome to the third of our four-part webinar series on championing best health, a primary care series on obesity, hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Scheer. I'm the Associate Dean for the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare providers, and everyone committed to providing the best clinical care for patients. So the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, Anishinaabe, and Saulteaux lands that are now known as parts of Treaties 6, 7, and 8 in the homeland of the Métis. University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just to remind everyone for logistics, if you have a question about technical difficulties or L3 programs or services, please use the chat feature in the bottom of your screen. However, if you have questions for Stasia and Laurie, or Stasia and Laurie, please use the Q&A feature of the webinar on the bottom. Please review what's been asked and upvote questions you'd really like to have answered. We cannot guarantee the panelists will be able to respond to all of your questions. A recording of the webinar will be sent via email to all those that registered with the PEARLS documents. Participants can claim CME credits and complete a personal development activity using the MyLink Lifelong Learning Plan tool. And so for more information, please visit the QR code on your screen. This activity has not been reviewed by the CFPC or Royal College. However, it is also eligible for non-certified credit. And Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise in your Main Pro Plus portal. So today we are very pleased to welcome back Stasia Hadjiyannakis and Laurie Clark. Dr. Hadjiyannakis and Dr. Clark will be presenting on exploring treatment options, what to consider and when to refer. And I think you guys have all met Laurie and Stasia at the previous sessions, but just briefly, Stasia is a pediatric endocrinologist and the medical director of the CHEO Center for Healthy Active Living in Ottawa. She's an associate professor of pediatrics, and has been an active member in the Division of Endocrinology since 2002 at CHEO. Her clinical advocacy and research interests are in the area of pediatric obesity, assessment and management with a focus on the development and evaluation of clinical tools like the 5 A's of pediatric obesity management and the Edmonton Obesity Staging System for Pediatrics that we heard a little bit about last session. Laurie is a clinical psychologist and clinical investigator with the Center for Healthy Active Living at the Children's Hospital of Eastern Ontario, so CHEO, where she works with an interdisciplinary team to help children, youth, and their families achieve their best health. Her areas of clinical expertise obviously included pediatric obesity as well as eating disorders and body image difficulties. And she's contributed to the development of key clinical tools, including as well the 5 A's of pediatric weight management and the Edmonton Obesity Staging System for Pediatrics, and is actively involved in clinical research and program evaluation. So thank you all for joining us for the third series, and we're looking forward as well to it next week for our last session, which will be on when care gets stuck, strategies for overcoming roadblocks. So welcome again. Thank you so much, guys. And I'm going to hand it over to you.
Thank you very much. It's nice to be here again with all of you. Thank you for coming out and spending your lunch hour with us again. Today, the focus will be on how to go from completion of your assessment to discussing potential management strategies with your patients and families. Oh, and then also, sorry, just thinking ahead to next week, if things come up for you during the session, I think next week we were meant to discuss tricky issues or places that we often get stuck. If there are specific things that you'd really love for us to address next week, if you wanted to pop them in the chat, we'll make sure to kind of focus on the things you're most interested in exploring with us next week. Sorry. So I'm going to go back to Alex, who we've been following since our first week together. So you met with Alex, you explored what his concerns were around body weight and health, and you completed your fulsome assessment of all 4Ms. So you completed a metabolic health assessment, a comprehensive biomechanical health assessment, explored a complete mental health screen, and a social health screen. And so Alex had no metabolic health issues, so blood sugars, cholesterol, lipid profile, liver enzymes were completely normal. Renal function was normal. And so he had stage 0 based on his EOSP for metabolic health. Biomechanical, he had some limited lower, some mild lower back pain, but it wasn't interfering with general activity, and he had some snoring. So those came up for him from a biomechanical perspective. Mental health wise, he had some mild body image concerns. Felt that his feelings about his body weight were holding him back socially, potentially impacting his confidence and comfort in social situations. And along with that, he had some perfectionism, which could at times was a barrier for him, and endorsed some emotional eating. And then again, from a social health perspective, there was that a relatively recent parental separation and some difficulties in communication between parents, and some different approaches to feeding and nutrition. So his overall EOSP stage was 1. So remember, stage 1 means some subclinical risk factors, but no clinically significant diagnoses in any of the 4Ms. And so at the end of the assessment, we take our 4Ms and out of those try to identify some potential things that might be driving weight gain for Alex, and then also identify some barriers to weight management for him. So once the assessment is completed, I find creating a table like this really helps me give some context to the young person that and family that we've met, and try from there to that's a nice conversation or starting point around health risk and potential areas of focus for management plans. So for Alex, from a potential driver's perspective, he has some biologic non-modifiable drivers of weight gain, including a family history of obesity, so polygenic obesity. He also was born large for gestational age, and we know babies born large for gestational age have a higher risk for obesity as children. And then he also endorsed some boredom eating, and then this dieting history, which meant that he had periods of sort of restrained eating, which could leave him more vulnerable for things like emotional eating or binge eating, but also potential biologic responses to that dieting history, including increased appetite signaling hormones and metabolic adaptation that can potentially promote further weight gain. And then we felt the barriers for Alex were some body image concerns. Maybe the perfectionism was causing him some challenges. And then the communication difficulties between parents with different approaches to feeding. And so when we, at the completion of the assessment, we'll meet with Alex and his parents to go through the findings of our assessment. So we reviewed with them the metabolic blood work. We discussed the 4 areas of health that we assess, and together tried to identify some areas that they feel would be good places to kind of focus on as we begin our work together.
So a little bit of a repeat, but again, we're sort of, if we go back to the 5 A's of pediatric obesity management, we sort of covered the ask, the assess in the last 2 sessions. And so, as Stasia said, we're going to advise them on, what we see as maybe some of the issues related to weight, or if there aren't any, we definitely let them know that as well, and kind of help them. So we do the advising them on what their health actually is, more than just the number on the scale. And then we're gonna, move into the agree on a plan with them, and then help them carry that plan out. And really our focus is on improving, health in a holistic way, and also taking into account quality of life. So we do think about and help paint a picture for the family as well, about sort of what the drivers of weight gain might be, and the barriers to weight management. And we do this not only so that, we're letting kids and parents know about, their actual health, but we also, it helps, I think, improve the chances of having realistic expectations about what the work together is going to do. So when we move into the agree and assist, we're going to provide education and resources. We're going to refer to appropriate providers if needed. And then the other piece is that, and I feel a bit sheepish saying this to family doctors, but arranging follow-up visits. And the research would say, you're supposed to see for the first, 6 months, see them quite regularly, and have, sort of several hours of contact. But that doesn't have to be just with the primary care provider. That can include, if they're seeing a therapist to work on mood and self-esteem. If they're knowledgeable about weight management and understand that this is part of the kind of picture of health for this child, then that, I think, it all sort of builds on the work that we all do. We can go on to the next one, Stasia. So again, making sure that we're upfront with our kids and families about what expectation, what they can expect in terms of changes on the scale. And oftentimes, I think we've sort of talked about this before, when we ask parents and kids what their biggest concerns for their health or related to their weight, it sort of falls into 2 categories. It's either the physical health risks that can come with living at a higher weight, but it can, or it's the sort of social impact. And so kids will say, I just want to be able to shop in the stores with my friends that are smaller than me, or I want to be able to find clothes for teenagers that fit me, that kind of thing. Or I just want the bullying to stop. And so we need to kind of help them understand what is likely, so that if they make all these changes and their actual health is better, they're not discouraged or stop because the number on the scale isn't decreasing. And so with lifestyle changes, we're not expecting a big change in weight, but there still can be a big change in health markers. And so part of the work we do is also helping kids feel good in their body, the bodies they have. And we oftentimes get into a bit of a discussion with teenagers who will say, well, I can't have good body image until, or I can't, not worry about bullying until my weight goes down, or I'm not going to join soccer until my weight goes down. And it's a bit of a catch-22, because, if we're too afraid to step out the door, then we're probably not going to be able to engage in healthier behaviors that would actually help to kind of manage weight better. Next slide, please. So when we look at behavioral and psychology interventions, and we're going to talk, of course, about behavioral, like lifestyle intervention, medication, and then bariatric surgery. When we're talking about lifestyle intervention, we, the research says multi-component. Of course, you're going to be one piece of that. We want it to be family-based, and I think that doesn't have to be fancy, to be quite honest, but I think you want to get the point across that, the health behavior changes we're talking about for, your kids or so and so in the family is actually should be for everybody, right? And so everybody has to be on board with these changes. Dad may have to give up his stash of chocolate that he thinks is hidden from the kids, but they all know where it is. Like, to bring it out in the open, you enjoy it, and then we move on. So it needs to have that family component. We don't want to single kids out or have a different plan for them. It needs to be individualized in the sense that it makes sense based on the assessment you did, and it's not just sort of giving out recommendations like eat less without actually looking at, having a conversation about how people are eating. It needs to be collaborative with families and with the kids. And it needs to be realistic. I'd like to be able to start to put just doable on slides, but it doesn't look very professional. So we stick with realistic. Stasia, next slide, please. Thank you. So I realize I have 5 rows here, but the 4 pillars of lifestyle interventions that we focus on are mental health, nutrition, sleep, and then physical and activity. And it used to be just activity. I think screen time gets its own little place in here as well. So when we're talking about mental health, I think you probably all recognize when there's sort of, significant depression, anxiety that's really impairing functioning. But some of the other things that we might not always think to ask about, of course, our body image, self-esteem, and then even just asking kids, anything in your life stressful, anything that you're worrying about, how do you deal with stress? How do you manage stress? And if you're starting to hear a lot of sort of worries and things, then maybe it's, hey, I wonder if we could see if there was somebody you could talk to about those things. Because, and the reason I think it's particularly important for weight management is because of the impact stress and anxiety often has on sleep, among other things. Nutrition, if our dietitian was here, she would tell you we are not talking micro and macronutrients. We are really talking about sort of regular eating and hunger management. And having a healthy relationship with food so that we have some flexibility in our eating, which is sometimes hard for kids. And I think if it's helpful, maybe next week, Stasia, we can talk a little bit about how we work with kids who, are on the spectrum or neurodiverse and may have difficulty with flexibility in thinking in general. And so nutrition definitely can be impacted. But we're really trying to get kids to eat regularly to fuel their bodies so that they're not going several hours without eating and then getting hangry after school, coming home, starving, because that sets them up for dysregulated eating and loss of control over eating. And we want them to be able to go to a birthday party and enjoy the cake and feel comfortable eating in front of other people as well. And within that, I'll just say one tip would be, asking kids if they eat breakfast and lunch, and if there's a reason why they don't eat breakfast or lunch. And sometimes breakfast, it's because they're not organized enough, or they're not hungry in the morning, or they're too anxious, and so their stomach hurts. And then at lunch, are they comfortable eating lunch? Do they not want to eat in front of other people? That's sometimes an issue for kids. Sleep. We talk about sleep a lot, and I think more and more we understand how important it is for both physical and mental health. So we want to make sure they're getting good quality and quantity of sleep, and looking at, do they have a regular sleep and wake time? Are screens in the bedroom? we want to try to get kids off of screens, ideally an hour before bed. Half hour would be lovely, and I would accept that with with very little disagreement. But oftentimes, especially for teenagers, it's having them charge things outside the bedroom really helps with sleep. And then, as we talked about last week, if there's concerns that there's a uh, obstructive sleep apnea or a sleep disorder, that they do have a sleep study, because that will really impair weight management efforts, attention, school, mood, all of the things really that we're concerned about. And then we also talk about sort of activity versus sedentary time on the flip side. And so looking for opportunities for organized and free play. We know that free play is actually really important for kids. It helps them to learn how to entertain themselves, helpful for parents if they can do that in downtime. And there are kids who are sort of introverts and need some downtime. Being in organized activities and groups all day long can be really hard on those kids. And so all introverts and extroverts both benefit from having some group activities, and then opportunities for free play that don't involve screen time. And it's really not about burning calories or, burning the most calories. We're looking for ways that kids can move their bodies and enjoy what they're doing. And the great thing about organized sports and other activities is that it's a place where kids can really gain some self-esteem, gain connections with other kids, which is especially important if kids aren't having trouble at school for any reason. Having another place where they feel confident can really help in terms of resilience. And we want to set them up for lifelong sort of enjoyment with physical activity. So we're not talking about often, sometimes parents, very well-meaning, will say like, well, we have a treadmill in the basement or something. Well, 8, 10, 12-year-olds, they'll tell me that's boring. Or walks are boring. And so, and I get it. They, it's not the most fun. So let's go to the park. Let's join. Is there an art class we can? It's all about sort of getting them out and just feeling more confident in different areas. And the flip side is screen time, where we do want to look at how much recreational screen time we're having, both in terms of just the amount, but also what kinds of things they're doing on the screen. Because some seem to be more harmful in terms of mental health than others. So if they're really involved in social media, are they talking to friends, or are they scrolling and comparing themselves to others? Are they playing violent video games? Are they playing, cooperative video games? Those sorts of things to think about. And of course, you're not going to have time to get into all the nitty-gritty of that. But having a sense, and whether or not, what happens when parents say you have to turn off the screens? Is there a meltdown? Can they have a discussion about it? That sort of thing. Next. So when we're talking about lifestyle change, we really want to normalize how hard it is to have healthy behaviors in our current environment. If you think about, if someone goes into work on the way home, how many restaurants and coffee shops and things do they pass on the way home? And if you're a tired parent, and it does feel easier to just pick something up on the way home. It really is difficult. Things are further away. Active transportation for some neighborhoods is difficult. It's not safe. And so you really have to put in a lot of effort to make these changes. And we often tell parents they're being super parents by doing some of these things that maybe other parents aren't thinking about for their child's health. We need to normalize that there are going to be ups and downs. And I will tell kids, like, please don't be afraid to come back and tell me the plan did not work. It doesn't mean it just means it wasn't a good plan for us. It's not a failure. There are going to be times you get sick or something else happens and you slip back into old habits, and that's expected. It doesn't mean all is lost. You're not starting back from ground zero. Acknowledge the realities that families are facing in terms of time, finances, other pressures on them. This is where these types of discussions is where motivational interviewing techniques can come in really handy to elicit sort of where people are in terms of readiness for change, so that you're also managing your efforts and expectations as well. I think that helps us as providers sort of know where do we kind of push more, when is it time to put more effort in, maybe time to back off a little bit. And we really are going for sort of, the slow and steady wins the race here. The quick fixes, and sometimes kids will come in and be like, nope, I'm gonna start going to the gym every day for an hour and a half. And it's hard to kind of dissuade them from that, or because usually, the big life makeovers don't last very long. Sometimes what we say is, okay, I understand this is where you're going. Why don't we set a goal together for maybe twice a week? And then if you go 7 times a week, like, you've far exceeded. But if you only get there twice, we've still met our goal, and you're still going to feel, I think, a bit better than if we kind of set the bar really, really high. And most times kids will go, oh, okay, yeah, that makes sense. Next slide, please. So when we get to the fourth A in the 5 A's, we're really looking to, we've sort of laid out what we, where their health is, what treatment options are. And so we're now going to try to agree on what everybody's interested in working on, making sure these are realistic outcomes. Parents and youth may have different health concerns and outcome goals, and that's okay. We, I think, always err on if a child has one thing they want to work on, like they want to work on sleep and the parents want to work on nutrition, I often talk to the parents about, let's go with what your child is like motivated to work on now, because if we can get some sort of momentum going here, then we can move to the things that maybe they're not so excited to work on. But we always kind of start with where the child is at, if there's a difference in what they want to work on. And even if, kids will still say, yeah, but I still want to lose weight. It's finding that what can we all agree on, and where can we start that conversation, or what's the goal we can all agree on, at least to start. Because once we get some momentum moving, body image can and does shift oftentimes in terms of, hey, I've gotten it there. I feel, as I start to do things, I feel more confident in my body, stronger. They actually see what we would call sort of the instrumental side of their body instead of just the ornamental, what it looks like. And that can really help. And then we need to be really clear what the goal is. And we'll talk, I've got some examples on the next page using those SMART goals. You probably was talked about for a few minutes at some point in your training. And then we're going to agree on the management plan. And so everybody knows what their roles and responsibilities are, ours included. And sometimes we need to sort of nudge parents to where they may need to support their kids more than they think they should, and explaining that, to get these things going, I am going to maybe ask you to make them breakfast again, even though they're older, because the idea is we want to get them eating it first and then work towards them preparing it themselves. So some examples of SMART goals, if we go to the next slide. These are just some examples that sort of popped into my head that often come up, but they're very sort of specific, so we all know if they've been met or not met. And this can be really helpful too in terms of If you have a youth and a parent who are disagreeing on things, and a parent sometimes feeling kids aren't doing enough, if we're really clear on what the goal is, then it's clear to everyone whether we've met the goal or not. So we're sort of moving away from we're going to eat healthier, or we're going to move more to what does that actually look like. So, mom taking away the bathroom scale, so we're not getting overly focused on a number and weighing ourselves every day. Sleep, do we have a solid sleep routine and a bedtime? Are electronics out of the bedroom? You know, can we have family meals a few times a week? Does that work for everyone's schedule? Can you guys pin down by the end of before you go to bed tonight which nights those are? Really specific, again, because then it's clear to everybody if we've met them or not. And then, so that's the one piece. And next, I'm going to pass it back to Stasia to talk about the pharmacotherapy.
So as Laurie said, the three main intervention or treatment options that we have include lifestyle intervention, pharmacotherapy, and bariatric surgery. We know that lifestyle intervention, the way you feed your body, the way you move your body, the way you sleep, the way you cope with stress, will improve health. And at the same time, we also know that weight change with lifestyle intervention tends to be modest. Of course, not everybody who has a higher body weight needs to lose weight to be healthier, but for those children for whom they have significant health concerns that are interfering with their health goals or with activities of daily living or with their quality of life, we do now have some additional tools in our toolkit that we can use. And so I just want to review a few of the pharmacotherapeutic options that are available for kids in Canada. The first is setmelanotide or Imcivree, which is a niche is a unique medication. It's a melanocortin-4 receptor agonist. The melanocortin-4 receptor is a hypothalamic receptor that binds a ligand called alpha MSH, which helps to signal satiety. And the production of alpha MSH is dependent on leptin signaling. So for kids who have monogenic or syndromic forms of obesity that impair leptin signaling, and they have an identified genetic diagnosis, they do qualify for a medication called setmelanotide, as long as they're 6 years of age and older. And it can be quite helpful for these kids who often are living with significant hyperphagia, which can be quite distressing. So a unique medication available in Canada, not covered by public insurance. Maybe now in Alberta. Actually, I think I heard that the province of Alberta will cover the cost of setmelanotide for children living with these rare genetic forms of obesity. We also have available liraglutide and semaglutide, both GLP-1 agonists. GLP-1, of course, is something your body makes anyway. It's made by your gastrointestinal tract. And GLP-1 agonists mimic the action of GLP-1. And GLP-1 in the body signals satiety, lets your body know when you've had enough to eat at a meal time, so acts at the level of the hypothalamus to do that. It also acts at the level of the beta cell to improve glucose mediated insulin secretion. So they're quite good medications for type 2 diabetes. Semaglutide seems to be result in a greater change in body weight, and I've heard that liraglutide for weight management will likely be discontinued in March of 2026. Both of these do have Health Canada approval for pediatrics in children who are 12 years of age and older. Access, however, is difficult, and our public pharma programs do not cover the cost of these medications, and the out-of-pocket cost for these medications is about $400 to $500 a month. Some will consider the use of metformin off-label to help with weight management, just to help support weight management. It has been shown to have some modest impact on body weight and is more well tolerated than the approved medication orlistat, which binds and inhibits absorption of fat from the diet, and that it has much less less desirable side effects for the degree of change in metabolic health or weight change. So sometimes the use of medications will come up for my patients. Sometimes people will come in and ask, is this something you feel I've heard about this. Is this a medication you feel I would benefit from? And at times the conversation will come up because I might introduce, we do have some medications now available to help support weight management in children. Are you interested in hearing about those? Then sometimes patients will say, yes, absolutely, tell me all about these medications. And others will say, well, do you think I need medication? And so then I find going back to our 4Ms really helpful. So let's see, how is your body doing? When we think about body weight, we evaluate, these areas of health that might be impacted. And so we'd go through the 4Ms. So any metabolic health issues. So for Alex, he has no metabolic health issues. Biomechanically, he has some maybe very mild concerns. And from a mental health perspective, there are things that we can work on to support Alex. So from my perspective, when I looked at, Alex's profile medically, I didn't feel that there was really a need to introduce a medication like a GLP-1 agonist or metformin for him, but just to continue, to support him from a lifestyle intervention perspective. The pharmacotherapy that we do have available does result in a greater degree of weight change than we see with lifestyle intervention, because it does disrupt some of the neuroendocrine mechanisms that make weight loss so difficult and make sustained weight loss even more difficult. And that's true of bariatric surgery as well. So bariatric surgery is available for youth in Canada at Sick Kids and Montreal Children's. The majority of kids who undergo bariatric surgery tend to have a sleeve gastrectomy. And the criteria for bariatric surgery in children are completion of growth, a BMI greater than 35 with clinically significant health complications, or greater than 40. Bariatric surgery is really a metabolic surgery. It changes, disrupts some of the neuroendocrine mechanisms that make weight management so difficult, and also result in significant improvement in insulin sensitivity, and a lot of the metabolic health issues do get better. We don't know the endurance of it, like the sustainability of those improvements over the long term, but there's some really impressive metabolic health improvements with bariatric surgery. The mental health concerns, however, it doesn't seem to, if there are significant mental health concerns pre-bariatric surgery, they continue to require support post-bariatric surgery, and also outcomes are better if the coexisting mental health issues are addressed and well managed prior to bariatric surgery. So in my experience, the families that are most interested or have the most questions about bariatric surgery are often families in which a parent has had bariatric surgery. Similarly, in the medication management, often the families that have the most questions about medication are families in which a parent has maybe tried a GLP-1 agonist with success or with concerns around the use of these meds. And both bariatric surgery and the pharmacotherapy, I should say, are really helpful metabolically from of course, blood sugar, fatty infiltration of the liver, lipid abnormalities. You can see some really nice improvements in those areas. So I think Laurie's gone through, depending on the health risk, and the health and the desired health outcomes of the patient and family, there may be a role for things like pharmacotherapy or bariatric surgery. We have to be really clear with our patients and families in terms of the outcomes that they can expect, their outcomes of interest, and then the expectations of how we get there, and support them in achieving those, and then reevaluating those health outcomes of interest periodically. Generally, in terms of referrals, if you've gone through your EOSP and you have a young person with stage 2 or 3 obesity, if there is the option of an interdisciplinary weight management program in your community, we do generally recommend that children who have stage 2 or 3 obesity based on the EOSP, that a consideration be given to refer to an interdisciplinary team for more intensive assessment and follow-up. I think, yeah, so I hope that we've given you kind of a little bit of a framework on how to use your clinical staging to help inform the health risk of the young person that you're seeing in assessment and follow-up, and based on that health risk and based on that EOSP staging, come up with a care plan that addresses the health outcomes that are of most concern for the patients and families that you're seeing. One of the toughest pieces, I think, when it comes to the navigating the new landscape with pharmacotherapy is that often in my experience I've found that for young people for whom I think these medications may be most helpful, they're left out or they're out of reach because of financial challenges or lack of coverage. And sometimes I also find myself struggling when maybe a young person wants a prescription for one of these medications where I maybe I'm not sort of feeling like it medically it may not be necessary, and how do I kind of work through that? Anyway, love to open it up to discussion.
Awesome. Thank you so much, both of you. And so just reminder to folks to pop your questions in the Q&A, and thanks to Cassie who's kicked us off. Cassie is just wondering, if we know a little bit about why babies born with larger gestational age are at risk for a higher body weight.
Yeah, I guess I don't know like in fine perfect detail, but I think that the larger gestational age babies, that's a clinical indication that they potentially developed in a more hyperinsulinemic environment, and that has it contributes. So insulin is a growth factor for babies, more so than any other hormone, and that seems to set them up for greater adiposity, like laying down of greater adiposity throughout their lifetime. I find that the larger babies tend to have just be larger kids and larger adults over time. I don't see adults, right? They just tend to be larger children over time, less metabolic health issues. Whereas babies born small, who developed in a potentially a more nutritionally deprived intrauterine environment where they had some growth restriction, those babies tend to have more metabolic health issues. There tends to be a greater degree of insulin resistance, PCOS, type 2 diabetes, those types of complications later in life. yeah, so birth weight and risk for obesity is a U-shaped curve.
Awesome. Okay, thank you. And Cassie's giving a plug also for next week around how to approach a conversation with a teen who's been dieting and counting calories. So that's a plug for next week. Genevieve is asking, a little bit about medications in terms of, if they start a medication, is that going to be then for life?
Oh yeah, that's a wonderful question. I think I approach it with my patients. So I guess similarly to any other prescription that I would write, I think many patients will ask that, like, do I need to be on it forever? And I share what we know of the research, which suggests that on average, in the research studies, when the medication is discontinued, there is weight regain. But again, that's a study of averages. So you can imagine within that population of study participants, some may have regained, some may have been able to sustain their weight, some may have gained some, but not all of the weight. So I always tell my patients that it will always be a conversation. So every time they come in to see us in follow-up, we'll say, how are you feeling on the medication? Is it helping you achieve the health outcomes that you're interested in? If they come in and are asking for a trial off, we say we could, as long as we see each other in follow-up and see how your body responds, look at your health over time and see if there's any role to restarting. Part of me wonders, like when I see some young people, I have had some young teens come off after a period of time. Sometimes I think, especially in teens who have significant biomechanical complications related to having a higher body weight, where they've felt a bit sort of trapped in their body or limited physically by their body weight, that with some weight loss, with the help of a GLP-1 agonist, that might free their body up for more movement and introduction of some more regular physical activity that they're now enjoying more, which may allow for greater sustaining of weight loss, even if they choose to come off. So I guess I keep an open dialogue about it. I share what we know about the medication in terms of what we know from the research studies, but take each patient as an individual, and if they feel like they want some time off or they want to reduce their dose, as long as we're seeing each other in follow-up to reevaluate that decision, I'm okay with it.
Okay. Yeah, wonderful. And Izokin has a really great question around little ones who are under the age of 2, who are really at the high end of body mass, and there's no overnutrition picture. So, is that a little bit of a different story in terms of action?
It's great. So yeah, for those who are under 2, so for those who are under 2, I think there are a few things. So if the growth velocity is normal, so their body weight is increasing quickly, but their length is normal, then I don't worry about an endocrine cause of that rapid weight gain. If they have an element of hyperphagia, or if there are any concerns for neurodevelopmental concerns, then I would recommend that a child who's gaining weight rapidly within the first couple of years of life be referred for genetic testing for possible monogenic or syndromic forms of obesity. Otherwise, when I see the children who are under 5 who have a higher body weight, a lot of times when I'm seeing the parents, it's about 2 things. Yeah, it's about those 2 things. One is there something going on that could be driving the weight that we can identify and address? And then secondly, are there any complications related to that high body weight? And in those children who are under 5, my main worries are related to biomechanical health. complications of gaining weight quickly. And so I'd be more inclined to refer for things like sleep studies, and watch for biomechanical complications, things like tibial bowing, and such. But I think I have seen most commonly that this happen in kids born to sometimes to moms with gestational diabetes, and so we just continue to encourage healthy nutrition. We don't deprive calories or feed any differently than we would feed or recommend for any other child under 5. That I find things seem to improve when they gain some gross motor milestones, when they enter daycare or school, things seem to improve. But I guess I don't have any wisdom in terms of intervention beyond like being sure to investigate for possible monogenic or syndromic forms of obesity with your genetics team.
Thanks, Stasia. James kind of has a related question I think we'll pivot to next, which is, is there any research on rates of persons with higher BMI in childhood returning to healthy levels on their own with minimal or no treatment?
So it's a more likely, so not as like I think it's close to 80% of people who have obesity as teens will continue to have obesity as adults. But I think the pre-adolescence or pre-puberty really group is I think we see a more of a possibility of resolution potentially, or remission. I would call it more remission of obesity potentially. But once puberty, if you have obesity at the time of puberty completion, I think that chance of going into remission by adulthood is relatively low.
Yeah, well, thanks, James. Great question. So Cassie has a question around what are some ideas about how to reframe ideas of desired weight loss versus challenges with losing weight and overall health?
So in terms of sort of how do we kind of balance that, maybe we want kids to engage in improving health behaviors without it being about weight, or have them do it while still being realistic that maybe they're not going to lose a ton of weight. It's tricky, and this is where sometimes we agree to disagree on some things, but and I recognize I have the luxury of time with kids to sit and I will ask them, so tell me about, like, why do you want to lose weight, or what would be different in your life if you did, because some kids do think it's the magic bullet that's going to, they've connected their weight with all any difficulties or stressors they have. So it becomes, if I just lost weight, the bullying would stop, I would have more friends, I would feel more confident, all of these things. And so when we talk about, well, my experiences, working with people, is that, even if you were to lose a ton of weight, if you're not feeling good about it, if we don't work on your body image, you're going to continue to not feel good about your body, no matter what size your body is. And helping them to see that how they feel and think about their body is not directly connected to the actual size of it. But also then if they're able to tell you why they want to lose weight, to talk a little bit about, like, I think you have to validate where they're at. And yes, that's terrible. And maybe start to find ways to open the conversation up to, okay, helping them to see that there are others, not because I think kids sometimes feel like I'm the only one dealing with this. And so if we can get them to see that, others might be kind of, not everybody is as perfect as I think sometimes in your head they are, having types of conversations like that. Or if they're a little bit oppositional, sometimes kind of going the route of, well, whose opinion is the most important? Yours. And so what do you think? Does being bigger mean you're less beautiful, or all these things? And if you can get them to kind of the place where it's like, well, I'm not going to let somebody else's idea of things, tell me how I should, what's, if I'm good or not, then maybe we can shift them a bit. But at least there's some good body positivity stuff out now that I think is much better than it was even 5 or 10 years ago, especially for girls. And I love all the coverage on the women's rugby that's been going on over the last month or so, because there's some really great role models for women on the Canadian team.
No, really awesome. And I have a question. I'm going to chime in, and since there's none left, just around adverse childhood experiences. So you alluded to in your case, Alex, around this divorce, but lots of different things that can go on. And Laurie, how often do you find that being a significant factor? And how do you work that into the whole management plan? Yeah.
Yeah, it's interesting. So I think the research would tell us that, experiencing traumatic events is, especially childhood trauma, is more prevalent in those who are overweight or obese. Even, if you look back in the childhood of adults who are living with obesity, we see more trauma. We could have a whole conversation on what, when is trauma and when is it, there's lots of discussions around, just because somebody has gone through something that you or I might consider traumatic, it's how they kind of viewed it and continue to view it, and what their resiliency level is. But I think when we need to, if we go back to the 4 M's and the drivers, is to take a step back and think about, so what does this kid need right now? Like, is their weight the most pressing issue? Because sometimes we actually say, okay, we're going to pause on our program because I actually think it's your mental health, or your family is in crisis. So we want to refer you to specific, mental health or crisis services, and then you come back to us, because if their mental health is terrible and they're experiencing a lot of PTSD or something, working on these things may not be. It's going to feel frustrating for them and you, because that's not where they are to they're not in the right place to work on these things. Again, though, on the other, some kids will say, I need, and parents will be like, I need to be able to feel like I'm doing something for my kid if they've really had, experienced a big traumatic event. And so can I, us working on the sleep might not get very far, but this is what I feel I can do for my kid right now. And that's what the kid wants to work on. But in the back of our mind, we know that there's other issues that may be impacting us. And sometimes it is about timing, I think.
Mm-hmm. Okay, awesome. Well, thank you. Thanks everyone for letting me interject my question. Okay, well, so looking forward to next week. So folks, we're going to be it's going to be an element of also bringing some of your challenges and things as well, and different things that have come up. So feel free to, well, I guess, Natasha, can I have folks send a little email your way?
Absolutely.
Yeah, you want to pop your email in the chat. So if a question comes to you over the next days prior to next week on things that you've confronted that you want us to forward to Stasia and Laurie before the session, please drop a note to Natasha in the background. And thanks, Natasha, for that. And we'll make sure that they get them. Yeah, thanks so much. It's so much wisdom. I just want to put you guys on speed dial all the time, because It's always a choose your own adventure every time we embark on this, right? There's always some new thing. It's like, what would Laurie do? So anyways, but thank you so much. Really look forward to next week. And thank you everyone for taking time today. And for those of you doing asynchronous, I think this is all going to really be helpful for the kids we take care of.